Hi, everyone. Welcome. Apologize for the late start, but we will get started in just 1 minute while everyone joins. Wonderful. Well, I'd like to welcome everyone. And like I said, I do apologize for a few minute delay, but welcome to the Firefighter Cancer Initiative seminar series. Today, we will be hearing from two of our doctors and researchers, Dr. Valentina Rodriquez and one of our PhD students, Kemi Ogunsina. Our topic today is thyroid cancer and firefighters. And I just wanted to give you a couple housekeeping items. If you have any questions, please type them in the Q&A at the bottom of the screen. The chat is disabled, so all of it will go through the Q&A function at the bottom of your screen in your toolbar. So if you do have a question, please type it in at any time. However, we will take questions at the end of each presentation. So once Dr. Rodriguez is finished with her presentation, we'll go through the questions, and then Kemi will present, and then we'll have questions after that. But please do feel free to type it in at any time, but we will hold questions till the end. And with that, I'm going to turn it over for a brief introduction from Dr. Natasha Schaefer-Sali from FCI. Take it away.
Yep. Hi, everyone. Great to see you guys this afternoon. I'm really excited to introduce our two speakers today. So first up, we'll have Dr. Valentina Rodriquez, who is an assistant professor of medicine with endocrinology, diabetes, and metabolism. She is working with our clinical staff of FCI and also our PhD student, Kemi. She's a clinician for many of our firefighters that we see here at And so she's going to be giving you guys an overview today on thyroid cancer and firefighters at large. And then following her presentation will be our PhD student, Kemi Ogunsina, who is writing her dissertation right now, looking at the elevated risk of thyroid cancer in firefighters. And so I'm really looking forward to their presentations today. I think they're going to be showing us some really exciting new topics in this field. And so I hand it off to Valentina. Thank you all.
Thank you so much, Natasha, and thank you for having me. It's a pleasure to be here. So today I'm going to talk to you about thyroid cancer in general from a clinician's perspective, and also tell you a little bit about how this applies to our firefighters. And, two questions that I'm going to be asking is, should we be worried and should we be doing things differently? And so my answer to these two questions is really, my opinion, I guess, is that we should probably be mindful, not worried, and maybe we should be doing things differently. So I want you guys to keep in mind three things as I go through these slides. One is that thyroid cancer survival and staging is very different when we compare it to other cancers at large. So thyroid cancer is very unique in that patients tend to do very well. Not always, but in general, they have an excellent prognosis. Secondly, not all thyroid cancers are the same. So it is very important to consider the subtype or type of thyroid cancer that we're dealing with when trying to figure out what a prognosis or future mortality looks like for our patient with the thyroid cancer. And lastly, as a physician, but really as a human being, I feel we should always practice from a place of do no harm. And so we must consider this always before implementing things such as, for example, a surveillance program. We want to really make sure that the benefits outweigh any type of harm that could occur for our patient. So this is just a representation of anatomy of the thyroid gland, which is again this butterfly-shaped gland that we're going to be talking about today. So this is a brief outline. So let's start with the thyroid cancer rates. So in general, we know that the incidence of thyroid cancer is increasing, and it's been very significant and consistent over the last 20 years. The good news is that this is mostly comprised of papillary thyroid cancers, which is the most common type of thyroid cancer, and also luckily tends to be the least aggressive. The big question when analyzing incidence is this a true increase in incidence, or are there really more thyroid cancers, or are we just discovering more of them? And this could this be leading to a detection or discovery bias? So most of us believe that there's probably a role for both of these, for both the detection bias and true increase. We know that ultrasounds are becoming more and more common in our practice. They are non-invasive, they're relatively cheap, they're easy, and so we are doing a lot more ultrasounds for our patients in general. Countries such as Japan and other Asian countries actually have instituted whole body screening ultrasound programs. So they are detecting a lot of thyroid cancers that way as well. And most of these thyroid cancers that are being detected are in patients who are asymptomatic. Now, if there is a true increase in thyroid cancer, which we also believe there to be the case, then the big million-dollar question is why? And unfortunately, we still are not 100% sure as to the why. So areas of research include the role of obesity potentially, and more significant for our firefighters would really be the role of flame retardants that have been associated with thyroid cancer. So how does it rank? So thyroid cancer most recently was ranked as the 12th most common cancer according to the NIH. There's about 44,000 new cases. Interestingly, most of these cases happen in women. So we do know that women are about 3 times more likely of developing thyroid cancer compared to men. So, perhaps we need to pay extra special attention to our women firefighters if these general statistics apply to our firefighters as well. In terms of deaths, mortality is about equal in both men and women. So both men and women die from thyroid cancer, unfortunately. Luckily, it's a very, very small percentage, and it's about equal in distribution. And actually, the death rate for thyroid cancer has stabilized over the last few years. So what are the risk factors for thyroid cancer? Why does it happen? So unfortunately, we don't really know. There is still no identifiable specific cause or risk factor for thyroid cancer. We know, again, thyroid cancer behaves differently from other cancers. So for example, whereas smoking and alcohol use many times is linked to other types of cancers, for example, lung cancer, this does not seem to be the case with thyroid cancer. Similarly, there's no specific diet that has been shown to increase or decrease your risk of getting thyroid cancer. So risk factors that we do know of is female gender, which like I said, 3 times more likely to have thyroid cancer if you're a woman compared to a man. Age also seems to be associated with thyroid cancer risk, such that the incidence of thyroid cancer really seems to peak between the 4th and 5th decade of life. And obesity is again an area of research. It is thought that patients who are obese have this extra fat that causes chronic inflammation and really makes there to be a higher chance for cancerous cells to develop. So mutations are at the basis of pretty much all cancers, and we can think about mutations as whether they are inherited or acquired. Inherited meaning it's something that you're born with, acquired meaning that this arises later on in life. And for thyroid cancer, the vast majority of the mutations are acquired. They're thought to arise later on within cells during their cell division. Only about 5 to 10% of all thyroid cancers are due to an inherited mutation. And so when we think about environmental risks and exposures, this becomes really important to really try to nail down to see what the association is, because the hypothesis is that these could be triggers for these acquired mutations. Familial thyroid cancers and rare genetic syndromes, again, much less common. So what are some of these environmental risk factors? So radiation has been known for a while now to increase the risk of both benign and malignant thyroid nodules, and so increase the risk of thyroid cancer. People who might have increased radiation risk or history include patients who as kids had a leukemia or lymphoma, for example, that needed to be treated with radiation treatment, or survivors of atomic bombing and nuclear accidents. These patients actually have been shown to have a 5 times increased risk for thyroid cancer. And interestingly, in the US, Americans that grew up in the mid-1940s to early 1960s may have been exposed to dairy products that were contaminated from atomic bomb testing. This atomic bomb testing was conducted in Nevada, New Mexico, and the Pacific Ocean primarily. I think it's interesting because when we look at some of the firefighter data and we look at firefighters in Las Vegas, for example, they seem to have much higher rates of thyroid cancer. And so how much of perhaps, this actual previous radiation exposure could be contributing to their increased rates is unclear. So flame retardants is what we are studying more and more of. It was found that higher levels of these flame retardants in people's homes were associated with higher rates of thyroid cancer. Unfortunately, though, the data has not been consistent. And so this is why more research is needed. And PhDs like Kemi are studying the role of PBDEs and exposure in firefighters and how this might be associated with increased thyroid cancer risk. Luckily, these compounds are being phased out of newer industrial use. That being said, our firefighters are going out into old buildings too. And so this is still a risk factor for them. So firefighters and thyroid cancer. So what kind of do we know? So we definitely know that firefighters are unfortunately at an increased risk of thyroid cancer. One of the first people to describe this was our very own Dr. Lee back in 2005. Him and his colleagues wrote this paper titled "Mortality in Florida Professional Firefighters." They looked at firefighters specifically in Florida, and they found that, amongst other cancers that firefighters were at increased risk for, thyroid cancer should be evaluated further because there seemed to be a correlation. A few years later, this meta-analysis came out looking at cancer incidence and mortality among firefighters, and it found that there was a 22% higher thyroid cancer incidence in firefighters compared to non-firefighters. Amongst other cancers again. And luckily though, thyroid cancer was not one of the cancers that was driving up firefighter mortality. More recently, Dr. Lee and his group looked again at Florida firefighters, and this time included women or female Florida firefighters. And again, I think this is really great that this was done because we know that females do have that increased risk for thyroid cancer. And in fact, there was this study showed that again, male career firefighters in Florida had almost 2 times a higher odds ratio of having thyroid cancer, and this was similar in female firefighters as well. So what kinds of thyroid cancers are firefighters being affected by? And I'm going to let Kemi talk to us about that because this is what a lot of her research is studying. I can tell you though, again, that type of thyroid cancer is very important when looking at thyroid cancer. So in general, when we think about the histologic types or subtypes of thyroid cancer, we can think of thyroid cancer as being broken up into 4 main groups. This slide has a few other groups that are much less common. The 4 main groups are the papillary thyroid cancer, which again is the most common. This pie graph shows it comprising about 80% of all thyroid cancers. I would say today we think this percentage is probably even higher. It's probably up to 90% of all thyroid cancers, followed by follicular thyroid cancers, which are often clumped with Hürthle cell carcinomas because histologically they look very similarly. So that would be the second group. The third group would be medullary, and the fourth group would be anaplastic. Lymphoma and sarcoma are much less common thyroid cancers. So the type, again, is very important when predicting survival rate. And probably the biggest contrast would be between anaplastic thyroid cancers and everything else. Luckily, anaplastic thyroid cancers are also the rarest thyroid cancers. They comprise up to max maybe 2% of all thyroid cancers. But if you see the 5-year relative survival rate for anaplastic thyroid cancer, even with just localized disease, it's only about 31% compared to nearly 100% survival rate for all other types of thyroid cancers. And if we look at papillary thyroid cancer, which is the most common type of thyroid cancer, not only is there a near 100% survival rate at 5 years with localized disease, but the same is true almost with regional disease, even meaning metastasis in local lymph nodes. And even when they have distant metastases, the relative survival rate is pretty good. So again, I can't say that thyroid cancers don't kill. Unfortunately, they do. But in general, when looking at papillary and follicular, which combined make up the overwhelming majority of our thyroid cancers, our patients do very well. So to make things even a little bit more confusing is within the papillary thyroid cancer group, which again, we said was the most common type of thyroid cancer, we can further subdivide these into different variants. And we now know that certain variants do portend a much more aggressive disease process. So if we go back in the slide and see, the patients who had the distant metastases that had a slightly lower survival rate, those patients tend to have tall cell variant papillary thyroid cancers or diffuse sclerosing variant papillary thyroid cancers. So the type of thyroid cancer is really important in estimating prognosis and overall mortality for our patients. So we can understand why for our firefighters, it becomes really important to not just, confirm that they are at increased risk of thyroid cancer, but really figure out which types of thyroid cancer they're being affected by. And Kemi's going to talk to us about that in a little bit. So we talked about mutations and how most thyroid cancers, overwhelming majority, have acquired mutations. And we've actually been able to study what some of these, what we call driver mutations are. And knowing driver mutations is very, very useful because it's helpful in predicting tumor behavior and prognosis as well. And many of our therapies and research into therapy for more advanced thyroid cancers are trying to target these specific mutations. And so, in the future, perhaps looking at molecular genetics of thyroid of our firefighters could also be very helpful in trying to determine what their prognosis is compared to the general population and if it's any different. So how do we manage thyroid cancer? So in general, surgery is the mainstay of treatment. Sometimes for people who have a little bit more aggressive papillary or follicular thyroid cancers, we use something called radioactive iodine treatment. And we really reserve chemo and radiation for the much less common, more aggressive types. So again, thyroid cancer is not like other cancers where so many of our patients are treated with very difficult courses of chemo and radiation. Thyroid cancer many times is considered cured with surgery. I always get this as a question from patients. Is there any diet I should take? Is there any supplement that I could take to, help my chances with my thyroid cancer? And the answer is no. So far, we have no data that shows that any specific diet or supplement can prevent or treat thyroid cancer. So shifting gears a little bit, and I bring this up because I think it might become important when we look at our firefighters, is this idea of managing thyroid cancer with active surveillance. And so active surveillance, as the name implies, is basically kind of just watching or monitoring these thyroid cancers with repetitive ultrasounds. So let me just preface by saying this is not a proposed management strategy for thyroid cancers at large. This should be specifically considered for certain papillary thyroid cancers, specifically small papillary thyroid cancers that are not in a part of the thyroid that could be involving surrounding structures outside of the gland. The reason why this technique is being studied more and more and starting to be adapted in some centers is because we have a lot of data from Japan that tells us that so many of these papillary thyroid cancers end up not causing any harm. And in fact, studies have shown that about 70% of small papillary thyroid cancers remain stable in size over several years without spread to lymph nodes, without spread to distant areas in the body. And of the rest that do grow, about 20 to 25% of these small thyroid cancers, they grow, but they grow very slowly and very predictably. And so we have time to kind of act on it with surgery if needed. So before applying this active surveillance technique, there's several factors that we need to consider: the patient's age, if they're able to follow up to have the surveillance, their anxiety level. I have patients that are anxious by surgery and they want to, avoid surgery at all costs. And I have patients that are anxious knowing that they have anything that could be malignant in them. And so they absolutely want surgery. Again, tumor size and location, very important factors to consider. The medical team, making sure that they're experienced. The surgical risks, because even though surgical risk is relatively low with the right surgeon, it can be higher in perhaps inexperienced surgery centers. And then I would say, what about firefighters? So should we be using this technique in our firefighter cohort? And so I think that we need more data for this, but I think it's certainly something that can be considered, especially since we are already surveying our firefighters so frequently for other cancers that they might actually end up being a good group to consider using this management strategy for. So screening. So do we screen for thyroid cancer for our general population? So the answer is we really shouldn't. So this came out in JAMA a few years back, the USPSTF recommendation statement for thyroid cancer screening, and it was a strong recommendation against screening. So basically, when you have a recommendation against something, it's because the thought is that the harm outweighs the benefit. And so, things to consider is that 70% of patients, when they're diagnosed with thyroid cancer, they're diagnosed well before the thyroid cancer spreads. So, the role of screening doesn't seem to help future prognosis for the vast majority of our patients. Also, remember that there can be high rates of false negative and false positive test results depending on who would be doing the screening. And so this needs to be considered also for our firefighters. So when we're trying to develop screening programs for our firefighters, we have to take what we know about the general population into consideration, all the while being sensitive to the fact that our firefighters are different because, again, they are being exposed to potentially, very toxic flame retardants. So what about our firefighters? So what we know is that firefighters, both men and women, have increased rates of thyroid cancer compared to the general population. We also know that firefighters have exposure to PBDEs, or these flame retardants, and that PBDEs in turn have been associated with higher rates of thyroid cancer. What we still don't know, though, is if our firefighters are more susceptible to more aggressive thyroid cancer types, and Kemi will give us a little bit more information on that, and if we should be implementing screening programs for firefighters that are different from our general population, and if so, when and how often we should be doing this. So I bring us back to this idea of detection bias or discovery bias versus true increase. This study that came out in JAMA last year, I think, was a very interesting study looking at firefighters, specifically those affected by the World Trade Center 9/11 incident. But it was a good study because it was the first study to really look at detection methods for thyroid cancer. And the question they posed was, are the rates of thyroid cancer among World Trade Center exposed populations associated with medical surveillance? So are these increased rates of thyroid cancer that we're seeing in this group of firefighters from the World Trade, are they higher because we are, surveying them so much more frequently? So the study looked at almost 15,000 men firefighters. Unfortunately, no women firefighters were included in the study. That were diagnosed with thyroid cancer from 2001 to 2018, and they controlled for age, sex, histologic specific types, and they compared the firefighters to a demographically similar group of men from Minnesota using data from the Rochester Epidemiology Project. And the outcomes they looked at was the number of incident thyroid cancers and their detection method, how they were detected, the age standardized incidence rates of thyroid cancer, and the relative rates comparing fire department and Rochester overall, and also by detection method categorization. And so this is a busy slide, but basically what they found was that overall, the age-adjusted incidence rate of thyroid cancer among the firefighters in World Trade was significantly greater than the demographically very similar non-World Trade Center exposed men. So like other studies have shown, these firefighters did in fact have much higher rates of thyroid cancer. However, they found that the difference might be explained because of the high rate of asymptomatic cancers that were being detected in the firefighter group. Interestingly, also, they found that the overwhelming majority of thyroid cancer that was found was papillary thyroid cancer, similar to the general population. And there were no thyroid cancer specific deaths or metastatic disease in any of these patients. And so the meaning of this study suggests that perhaps increased rates of thyroid cancer in World Trade Center exposed firefighters may be associated with heightened surveillance rather than an actual increase in disease. And so again, like the general population, I believe that there's probably a mix of both. I do believe there is a true increase because we know that our firefighters do have more exposures to toxic things. But I think we need to keep this in mind when we're thinking about surveillance programs for firefighters, because we don't want to end up doing more harm than good, exposing perhaps our firefighters to more unnecessary tests that may not in the end change prognosis or survival. So again, the potential adverse effects of screening too often or at all, sometimes we talked about potential for false positives, false negatives, but also, we have to think about personal and financial costs, increased doctor visit, increased anxiety, costs of surgery, which may not even be indicated if we are saying that perhaps the most common type of thyroid cancer, which is the papillary thyroid cancer, is what's being seen in our firefighters. And of those, so many of them are small. And so perhaps we could use active surveillance for many of these patients. So it's a lot of things to kind of balance and consider. So for the firefighters, if any of you guys are listening in this seminar, what I do recommend, if you're found to have a thyroid nodule, whether through a surveillance program or just by feeling your neck, it's really important that you see an endocrinologist, because you really want an endocrinologist to evaluate your ultrasound or send you for one if you haven't had one yet. Many times nodules are kind of misread on ultrasound, and so we really want to make sure you first of all have a true nodule, and secondly, we want to make sure if it's appropriate or not to biopsy. Also, you should always have a TSH level, which is an indicator of how your thyroid is working. So to conclude, histologic subtypes become very important when determining the utility and necessity of screening programs for thyroid cancer. As we saw, in general, the most common type of thyroid cancer, which is the papillary thyroid cancer, has a very excellent survival and prognosis, but we can't say the same about all papillary thyroid cancers. For example, the tall cell variants are known to be more aggressive. And of course, we have medullary and anaplastic thyroid cancers as well that are definitely more aggressive. Secondly, I think that pooling resources into a national database will help better identify whether less common or more aggressive thyroid cancers are impacting our firefighters more frequently. It becomes really hard sometimes statistically to prove that that firefighters are being impacted by more aggressive thyroid cancer, because more aggressive thyroid cancer is also the less common in general. So we usually need a bigger N to evaluate this. So, you know, by pooling all the data from different states and firefighter departments, this might help elicit these differences a little bit more easily. The association between specific firefighter work exposures and thyroid cancer types are being studied, but they still need further clarification. And lastly, there may be a future role in studying molecular genetic testing in thyroid cancers affecting firefighters. Again, you know, those driver mutations are also important when we consider prognosis and survival. So with that, I thank you, and I turn it over to Kemi, who has done awesome work in a few of these areas and will share with us some of her work.
Thank you, Dr. Rodriguez. I don't know if she wants to take the questions or I just go ahead.
Dr. Rodriguez, we did have 2 questions that were specific to your presentation.
Sure. Yes, I see them. Yes, I will answer them now real quick so that we can let Kemi start. So one question was, is the Japan data set general population or firefighter specific? It was the general population. So it was not firefighter specific. And unfortunately, I don't think there was any kind of subsets of firefighters, but it would be really interesting to look at. In the United States, there's a lot of work being done in Sloan, looking at the active surveillance kind of strategy for management. And so it would be interesting to see if anywhere in their demographics they mention firefighters. They don't, to my knowledge, but it's definitely something that I think in the future would be interesting to study. The other question I had was, if I had thyroid cancer in the past, am I more likely to get another one or a different cancer in the future? If yes, which cancers can thyroid cancer run in the family and genetics? So for the majority of thyroid cancers, again, they don't tend to be familial. So about 5 to 10% of all thyroid cancers are what we call familial. They tend to run in families. They are associated with inherited mutations, and some of those are actually a part of a greater genetic kind of syndrome, which can manifest with other cancers. So the answer is maybe. So if you've had a thyroid cancer in the past, you may be at increased risk for developing a different cancer. It's very unlikely if you don't fall in this subset of familial or genetic kind of mutations. So the good thing is we many times do run a check for mutations on pathology. Once you have the surgery, we look at the cells, we look at the histology, the subtype, and we can run that information through for looking at which mutations are involved, and that can clue us in sometimes as to if you should be, you know, screened a little bit differently. But in general, if you do have a familial type of thyroid cancer, you could be at increased risk for another thyroid cancer. If you don't have any family history and you're not found to have a familial thyroid cancer, usually having thyroid cancer once doesn't put you at higher risk of having a different or another thyroid cancer.
All right, thank you, Dr. Rodriguez. So I'll be discussing my research study looking at the distribution of histologic subtypes of thyroid cancer among firefighters. So we've talked about the high risk of thyroid cancer among firefighters. Dr. Rodriguez had run through these studies. This first study was by Dr. Lee that showed an increased risk of thyroid cancer among firefighters compared to the general population. And this second study was by Jillian et al. It also confirmed an increased risk of thyroid cancer among firefighters compared to the general population. And from what Dr. Rodriguez said, papillary thyroid cancer has the highest, incidence compared to the other histologic subtypes. So we have follicular, we have HER2 cell, which is also called oxyphilic, we have medullary and aplastic. So these are rare types, but then because they all run different courses, like some could be aggressive, while some run a less aggressive course than the others. For example, papillary is less aggressive most times, while follicular Hurtzel, medullary, and aplastic could be more aggressive. So that's why it's important for us to look at the different histological subtypes within the firefighter service. And the complications of cancer, of thyroid cancer, could be recurrence, persistence, metastasis, and or death. So the objective of this study is to determine the distribution of histologic subtypes of thyroid cancer among firefighters compared to non-firefighters in other occupation groups. And our hypothesis is that the proportion of papillary thyroid cancer will be higher among firefighters compared to non-firefighters. And also a higher proportion of firefighters will present at an early stage compared to non-firefighters. Our third hypothesis is that firefighters will be diagnosed at a younger age compared to non-firefighters. So the data we used for this analysis is the FCDS, that's the Florida Cancer Registry data, which is linked with the Fire Marshal Office data from 1981 to 2014. So we had, we started with 40,672 cases of thyroid cancer. From this, within this case, we had taken out benign cases and volunteer firefighters. From this 40,000, we took out people who were less than 18 years of age or who were older than 70 years of age. So that was about 7,500. And then we ended up with about 33,000, from which we took out, excluded those records that were missing occupation because we needed the occupation codes. So we ended up with 8,291 for our analytic sample. For our analysis, what we did was, based on the 2010 standard occupation codes, the census standard occupation codes, we categorized the participants, the tumor records, into 5 different occupation groups. So we had firefighters, service workers, white collar, blue collar, and other occupation groups. And using the ICD-03 histologic codes, we categorized the different histologic subtypes of thyroid cancer into papillary, follicular, and then every other rare thyroid cancer was grouped as others. So the other group was majorly made up of oxyphilic, medullary, carcinoma of non-specified, and aplastic. And I just want you to note that the histologic subtypes that made up this group called others are like the really aggressive types of thyroid cancer. The FCDS data actually uses the SEER 2018 summary staging to stage the tumor. And the summary staging is in 9 stages, but for the purpose of this analysis, we condensed it into 3 stages, early stage, late stage. And for those tumors that did not have enough information on staging, we grouped them as unknown stage. For our occupation groups, so this is just a broad definition of what each occupation group entails. So for the service, we had protective and non-protective occupations. So talking about police officers, and then private household and private household occupations. So we're talking about cleaning services, building services, personal services, people that offer food services. They all fall under service occupation. For white collar, we have executive professionals, managerial positions, people in administrative positions, technical, clerical, and sales positions. And then for the blue collar workers, we have precision production, we have construction workers, we have machine operators, we have assemblers and inspectors, transportation, material moving operation, crafts, repairers, helpers, and laborers. And then for others, the group which we called others, we included farmers, for people working in forestry, and people working in fishing, homemakers, students, retired, and disabled. We included farmers in this category because we had very, very little data for farmers. For our analysis, first off, we conducted a descriptive analysis to assess the socio-demographic and tumor characteristics of participants in firefighting, service, white collar, blue collar, and other occupation groups. And then we conducted an overall comparison of all the occupation groups using chi-square test. And subsequently, we did a multiple pairwise comparison comparing firefighter to each occupation group. So we looked at firefighter compared to white collar, firefighter compared to blue collar, firefighter compared to service, firefighter compared to other occupation groups. And subsequently, we conducted a stratified analysis to examine the distribution of thyroid histological subtypes by age. We stratified by age, we stratified by gender, and then by tumor staging, comparing firefighter to each of the occupation groups. And finally, we conducted a multinomial logistic regression to examine the relationship between histologic subtypes and occupation groups. And in this model, we adjusted for age at diagnosis, gender, tumor stage, diagnosis year. And we also calculated adjusted odds ratio, 95% confidence intervals, and our p-value was set at significance level of 0.05. So I'll go on to the results. So these are our findings. If you look at the mean age at diagnosis, we found that firefighters were more likely to be diagnosed at a younger age, 43, about 44 years, compared to other occupation groups. So, and this was significant when we compared firefighters to white collar and blue collar. So it was significant overall when we combined this whole group and compared them with firefighters. It was significant that firefighters were diagnosed at a younger age. And then when we looked deep dive to look at each group compared to firefighter, it was significant for white collar and blue collar workers. And then by gender distribution too, we found out that firefighters had a higher proportion of males compared to females. And this difference was significant compared to each of the other groups. The distribution in gender was significantly different compared to each other group of workers. And looking at the race distribution, we found that the overall p-value was significant comparing firefighters to non-firefighters. And when we look at it pairwise comparison, it was only significant comparing firefighters to service. Also for ethnic distribution, the overall p-value was significant, but when we looked at pairwise comparison, comparing firefighters to each of the occupation groups, it was significantly different comparing firefighters with service and other occupations. So when you look at firefighter and service and then firefighter and other occupation, there was a significant difference in ethnic distribution. Then looking at our stage at presentation. So this is the stage at which they presented at the hospital with the tumor. We found that overall, the p-value was significantly different for stage, but p-value for pairwise comparison was also significant with service, white collar, blue collar, and other occupations. So it was significant comparing firefighters to other occupations. So, and then when we look at the diagnosis year, which is the year in which the patients were diagnosed, overall p-value was significant, and p-value when we compare firefighters to service, white collar, and other occupation was also significant. So this is the histologic subtypes of thyroid cancer. So we have papillary, follicular, and then others. I explained earlier on that others is all the other rare subtypes of thyroid cancer that are usually aggressive. So we combine them all and place them in this category called others. So we see that there was significance in terms of comparing the distribution of the different histologic subtypes, comparing firefighters to each of the occupation groups. And this is our stratified analysis. So where we looked at the distribution by age and gender and tumor stage. So we can see that there's no significant difference comparing the histologic distribution by age, comparing firefighters with each of the other occupation groups. These are our p-values, so they were not significant. They were Bonferroni adjusted p-values. And when we compared, however, when we compared by gender, the distribution of the histologic subtypes, we found that it was significantly different comparing firefighters to service, firefighters to white collar, firefighters to blue collar, firefighters to others. So this is when the gender is male. However, when the gender is female, there's no significant difference in the distribution of histologic subtypes comparing firefighters to other occupation groups. And there was also no significant difference in the distribution of histologic subtypes looking at tumor staging comparing firefighters to other occupation groups. So let's look at our multinomial logistic regression. So here we're looking at the risks of the different histological subtypes, comparing firefighters with other occupation groups. And then in this model, we also show in some predictors to look at what are the predictors of the different histological subtypes. So this first chart is looking at the risk of others, which is the very aggressive types of thyroid cancer compared to papillary histological subtypes. So when we look at service workers, white collar, blue collar, and others, we actually found them to have higher risk. So anything to the right of the red line is significant. So we found significantly higher risk of others, of having other subtypes of thyroid cancer compared to papillary, looking at service workers relative to firefighters, looking at white collar relative to firefighters, blue collar relative to firefighters, and others relative to firefighters. So these other occupation groups, in other words, I'm going to put it simple, these other occupation groups had higher risks of having other types of thyroid cancer compared to firefighters. So firefighters had higher risk of papillary than the other aggressive subtypes. And when you look at other predictors of having papillary compared to others, we found that if you're in a younger age, 30 to 49, if you're age 18 to 29, you are less likely, you are significantly less likely to have others compared to papillary. For race wasn't significant in this chart. And then for those who were diagnosed at an early stage, and you were more likely to be diagnosed with others compared to papillary. However, those diagnosed at an unknown stage compared to a late stage, you are more likely to be diagnosed with others compared to papillary. So, and this other chart looks at the risk of having follicular compared to papillary. So we can see that the other occupation groups had higher risks of having follicular compared to papillary, but this was not significant. You can see it crosses the red line. So this is not significant. Anything that's on the right side or totally on the left side is considered significant, but anything crossing this red line is not significant. However, we can see that women were less likely to have follicular compared to papillary cancer. And also the year of diagnosis. So if you were diagnosed between 1992 and 2002, you were less likely to be diagnosed with follicular compared to papillary. And also if you're diagnosed between 2003 and 2014, you're less likely to be diagnosed with follicular compared to papillary. Looking at race was significant here. So you can see that non-whites were more likely to be diagnosed with follicular compared to papillary. And also tumor stage was also significant here. So if you are diagnosed with early stage tumor, you were more likely to have follicular compared to papillary. And if you are diagnosed with an unknown stage of if your tumor was classified as unknown stage, then you're more likely to have follicular compared to papillary thyroid cancer. So in conclusion, what we found in this study is that overall, firefighters are diagnosed for thyroid cancer at a younger age than non-firefighters. And when we do a deep dive to look specifically at what groups, we see that firefighters are diagnosed at a younger age compared to blue-collar workers and white-collar workers. Also, we found that the distribution of the histologic subtypes of thyroid cancer is significantly different comparing firefighters to all the other occupation groups. However, we did not see any significant difference in tumor stage at diagnosis comparing firefighters to other occupation groups. Firefighters are less likely to be diagnosed with follicular subtypes and significantly less likely to have other subtypes of thyroid cancer compared to service, white collar, blue collar, and other workers. So basically what we are saying is firefighters were more likely to be diagnosed with papillary thyroid cancer compared to orders of follicular when you compare firefighters with these other occupational groups. Other significant predictors of histological subtypes of thyroid cancer that we found was gender. So women were significantly less likely to have follicular compared to papillary when we compare women and men. Also, the age group 30 to 49, they were significantly less likely to have follicular or other subtypes of thyroid cancer compared to papillary when we compared them with those people aged 50 to 59 years old. So our next steps for our research is to examine the association of individual and occupational predictors of PBD exposure, because like Dr. Rodriquez said, firefighters are exposed to PBDEs, which has been found to be carcinogenic and suspected to be associated with thyroid cancer. So our next step is look at individual and occupational predictors of PBD exposure and serum PBD levels among firefighters. And also we are going to explore the role of BMI as either a mediator, a moderator, or both in the association of serum PBD and thyroid dysfunction among firefighters, because PBDE is stored in adipose tissue, and firefighters do a lot of activities that could involve them breaking down fats, and this could release more PBD into the blood, into the serum, and this could have an effect on thyroid cancer. So we are going to explore that also in future. So thank you very much for your time. If you have any questions for me to answer. So I'll be taking any questions if there are questions.
I don't see any questions in the Q&A chat, but if anybody has any, please, feel free to type it now for either of our presenters. We want to say thank you so much to Dr. Valentina Rodriquez and Kemi Ogunsina for their presentations today. Dr. Schaefer-Sali or Dr. Caban Martinez, would you like to make any comments?
I just want to say thank you both for presenting. I think you both did a phenomenal job. Really, really great data you were showing today.
Yeah, and I would like to echo that sentiment too. I think this is really one of the wonderful things about the Firefighter Cancer Initiative, where it bridges sort of clinical practice and epidemiology, and field data collection with our first responders. This type of work wouldn't happen without our first responders, so I'm thankful to them, for being here today and supporting this research work. And if you were shy to ask a question, please do reach out to Dr. Rodriquez or Ms. Ogunsina on asking about this study. Thyroid cancer is very important to us and how we potentially screen for it, diagnosis and treat it for our first responders. And your feedback is essential to making the research a better product. So thank you.
Thank you so much. There was one question earlier about fire investigators being able to participate in our surveys and in our testing. And we did type out the answer. The answer was yes. So all subgroups in the fire service are invited to participate in our studies, both the surveys and the testing. I just want to make a note of that.
Yeah, absolutely. And just a quick shameless plug that for the first responders that are, and firefighters and EMS that are on this call, Dr. Barbara Malay has added fire investigator questions to the personal exposure record app, and that's available to you. So if you are interested in recording your personal exposures from your individual arson investigations, please do consider using that app. It is free and it was designed by fire investigators for fire investigators, and that's at per.miami.edu. It's available both in the Google Play and the Apple Store for access.
Great. Well, thank you very much. And I did want to let everyone know that next month on March 23rd, again, Tuesday, the fourth Tuesday of the month at 12 p.m., we will have another seminar. It is going to be about our draft study, so direct respiratory assessment of firefighter tactics cohort study. And that'll be presented by members of our FCI team, Dr. Alberto Caban-Martinez, Dr. Natasha Schaefer-Solly, Hannah Kling, our APRN, Amy Green, and Johanna Garibaldi, who have been working very hard on this study. They'll be presenting, sorry, next month. So March 23rd, Tuesday at 12 p.m. And again, we want to thank you so much all for attending, for joining. This session has been recorded and it will be posted on our YouTube page, Sylvester Comprehensive Cancer Center. And if you go to the playlist, the Firefighter Cancer Initiative has a number of seminars and different videos for you to take a look at, this included.
Thank you, everybody.
Thanks, everyone.
Bye.
Have a great day.
Have a great afternoon.